Buongiorno a tutte e buongiorno a tutti. È un grandissimo piacere per me introdurre brevemente la collega Kim De Jong. I already told you, Kim, that I will tell something about your life you know very well, so I will talk in Italian for our audience, e ringraziare a nome di SPR Italia i colleghi Gianluca Lococco, Salvo Gullo, e tutti i colleghi, Angelo Compare, tutti i colleghi che hanno collaborato alla creazione di questo webinar, che trovo estremamente interessante per la figura scientifica di Kim De Jong, che ora brevemente introdurrò per chi non la conoscesse. Kim ha ricoperto vari ruoli in SPR ed è nell'editorial board di Psychotherapy Research, e ha anche ricevuto numerosi premi per la sua attività scientifica. Si è laureata in psicologia e metodologia della ricerca all'Università di Amsterdam nel 2000. Si è dottorata in clinical psychology nell'Università di Leiden nel 2012. Ha lavorato in numerosi contesti clinici territoriali dove ha svolto soprattutto attività di ricerca. Ha fatto dei periodi di visiting importanti, il primo più breve alla Brigham Young University, dove ha lavorato con Michael Lambert, e uno più lungo alla University of Pennsylvania, dove ha lavorato con Robert de Rubeis. Attualmente è Assistant Professor in Clinical Psychology all'Università di Leiden. L'attività di ricerca, i topics di ricerca di Kim sono molto vicini agli interessi, direi in generale ovviamente di SPR International, ma secondo me in particolare agli interessi anche di SPR Italia. Ci sono molti colleghi che credo attendano la sua presentazione, le sue riflessioni con molto interesse. Perché? Perché quello di cui lei si occupa principalmente sono gli outcome terapeutici, le differenze, direi, tra i diversi outcome terapeutici e lo sviluppo di strumenti e di metodi che sono tesi, diciamo così, a migliorare l'outcome dei nostri interventi clinici. Possiamo dire, insomma, che Kim segue due linee di ricerca. Uno che rientra nell'ambito dei personalized mental health care, dove sostanzialmente Kim con grandi database misura gli outcome in linea, direi sostanzialmente, con il vecchio adagio da tutti noi sempre molto rispettato, che è what works for whom. E anche studia quelli che noi chiamiamo i therapist effects, cioè diciamo i contributi degli interventi dei terapeuti, in modo da mettere a fuoco come mai certi terapeuti ottengano, diciamo, risultati migliori di altri. Oggi Kim è qui per parlarci di un metodo specifico che si chiama Routine Outcome Monitoring Feedback, il ROM, R-O-M, e naturalmente ci parlerà degli strumenti coinvolti in questa attività di feedback, su cui lei ha pubblicato lavori molto interessanti, e di alcuni costrutti pertinenti relativamente appunto a questo metodo. Sono costrutti a ponte tra la clinica e la ricerca, per esempio quello di not on track patients, il not patients, cioè il paziente che non è in linea con quello che è il miglioramento che ci si aspetterebbe da lui secondo gli interventi clinici che operiamo. Ma ovviamente non voglio rivelare nulla, anche perché la presentazione di Kim, soprattutto se l'avete già vista, è anche piuttosto appassionante dal punto di vista di che cosa effettivamente può insegnarci per migliorare con il feedback il nostro intervento e quindi l'outcome. E quindi con grande piacere e con onore le do la parola, le cedo la parola. Kim, thank you for your talk, and I give you the voice. You can start. Thank you again and welcome in Italy.
Well, thank you, Vittorio, for and SPR Italy for the invitation to talk about my research here to all of you. My Italian is not great, so I'm glad to be able to do this in English, although I did spend 3 lovely weeks at the University of Bergamo in 2018, but it was not long enough to become fluent in Italian. So, so I'm going to talk to you today about the research on routine outcome monitoring in psychotherapy. And I'm going to share my screen right now and see if you can see my PowerPoints then. And let me see if I can then do this, I guess. All right. Can you all see my screen well?
See?
Okay,
yes,
good.
yes, yes.
All right. As a starting point, I wanted to ask, but I'm actually not sure if now that I'm on screen share that I can actually see it, but I think you can do like a little hand signal or something like thumbs up or something. How many of you already work with a form of routine outcome monitoring? Just to get an idea of sort of how much I need to explain. I think there's like a response button in Zoom that you can use to do like a thumbs up or something. So if you have worked with routine outcome monitoring before, can you give me a thumb from Zoom if that works? I don't see any thumbs, so either nobody worked with it or, oh wait, the chat window might work. I see a couple of people putting something in the chat window, so that might be a better way. So if you have, all right, I see a couple of people, 4 responses so far of people familiar with it. Okay, so the majority of people are not yet working with it, but may have heard about it sort of through the scientific literature, etc. Okay, thank you. That gives me a bit of an idea as to sort of how detailed my explanation should be. If you're all already working with it and well familiar with it, I could breeze over that a bit more and focus a bit more on other things. Okay, so now, when we're talking about routine outcome monitoring, maybe the first question is, what is it exactly? And I think in a way, it is kind of easy to understand what it entails, but there's still a lot of variability in how it's being executed, how it's being implemented. So I think it's good to actually talk about this for a little bit to give you an idea of what ROM entails and then what kind of different forms of ROM there are around. And so this is a very straightforward ROM graph where you see that there is like a threshold for normal functioning, and then this is on the LQ45, and then you see a decline in symptom severity over time, so over the session. So this is a pretty sort of the most straightforward type of ROM that is around. Just to give you an idea of sort of what it is. Now, first, it might be good to briefly talk about why do we need something like ROM? I mean, we're all clinicians, we all are well trained. Why would we need something like ROM to tell us how the patient is doing? Well, the reason is actually that when we look at the results in routine practice, that we see that the outcomes are not remotely as good as they are when they are studied in clinical trials. And you see that only about 35% of patients improved. And this is an American study, but very similar numbers have been shown in other countries. So there's like a lot of information from, for instance, the UK, the Netherlands. And what we see is that at least a third of patients do not benefit sufficiently from treatment. And then in some cases, the numbers are a bit higher. In some cases, they're a bit lower. But all countries that I've seen data on for this is that about a third or more of patients do not benefit sufficiently from psychotherapy. And monitoring patients' progress, which is referred to as routine outcome monitoring, is considered to be a potentially effective way to improve outcomes. And we're going to talk a bit more about its effectiveness later in this talk. Now let's continue to think about what do we mean when we talk about routine outcome measurement. Now this is a kind of a classic outcome measurement, which is a pre-post. This again, the OQ45. Let's focus mainly on the black line or the dark gray one, where you see that between pre-treatment and post-treatment, there is a reduction in symptoms overall. Now, this is actually one of my own patients that I treated when I was working in the United States. And so I used the OQ45 to measure the entire course of treatments. And you see that this looks like a relatively successful treatment. If you were just to look at this result, you would think, well, this looks good. Now, let's look at the session by session scores on the BDI. This was the back depression inventory. And we see a very different image in the sense that this is session by session measured, and it doesn't look as straightforward at all. It's in fact a very rocky type of treatment course. And so I can talk you a little bit through it. This was a recurrent depression, and this was a patient who came to us because she felt she was getting more and more depressed again, and she came in for booster sessions. I don't know if you have booster sessions in Italy, but typically it's like once every 3 weeks you come in for a session to kind of refresh your treatment skills or your kind of coping skills that you learned in a previous course of therapy. So it's basically kind of meant to like reinstall using the skills that you already learned in a previous therapy course. And so that's how we started at first. So the first couple of weeks, this is a mild level of depression. The client came in for booster sessions every 3 weeks, and she also started on antidepressant medication. That was something that she had already started when she got back to the clinic. Then she went home for Christmas, and she ran out of her antidepressant prescription over Christmas while she was staying with her parents. And as you can see, when she got back after the Christmas break, she had evolved into a quite severe level of depression. Well, this of course is very easy to understand when you go off your medications cold turkey, but you can clearly see in the graph that was what's going on. And so what happened is that she got back on it with the psychiatrist, and then first she increased a little bit. I no longer thought it would be wise to only see her once every 3 weeks, so I increased the frequency of our sessions to every week. And so that's how we continued for the rest of the therapy course. And what you can see is that here, probably the antidepressant medication is kicking back in. So she's starting to feel a little bit better. And also, I think for maybe seeing me more frequently might have helped her a little bit. But, you know, still here, she was not really at the level that we wanted her to be, because she was just the same level as that she was when we had started therapy. So, and what I could also see, because we were doing these weekly measures, was that in fact her symptoms were increasing over time. And so that really pushed me as a therapist to kind of look at what can I do differently? How can I use maybe different interventions, different approaches with this client to get her symptoms to drop a bit further. And so at first we had a bit of an increase, as you can see, and then there was like a little bit of a breakthrough moment in this session, and then her symptoms started to drop again. And luckily, we were able to end treatment well in the normal range. But you can see a huge difference between looking at a treatment pre-post and looking at a treatment on a session-by-session basis, where you can see all the dynamics. But more importantly, I think here, especially in the phase between session 8 and 10, it is hard as a clinician to really see whether a patient is in fact improving or not, because it's very subtle differences. And I think this is where having standardized measures can actually help us decide, see, wait, the client is not improving. In fact, they're like even worsening a little bit. What can I do differently for this client to help them in a better way, that I think has the value of routine outcome monitoring? And that shows, at least for me as a clinician, this is very clear. But of course, that is also, I'm of course an advocate of this type of work, and but I found that many people are able, when they're working with routine outcome monitoring, that it offers them something that maybe they wouldn't have been able to perceive themselves without these measures. And that can be anything from risk items, you know, realizing that a client still has suicide ideation, even though you haven't talked about it anymore, to, you know, worsening on a graph like this, for instance.
Kim,
now,
sorry.
Here we see.
Kim?
Yes.
Hello, I'm Gianluca.
Yeah.
I want just to translate this slide, if you agree, because I think that
Sure.
There are some concepts words could be explained in Italian. Kim adesso ci ha fatto vedere quindi una differenza tra la valutazione continua nella slide precedente con l'outcome questionnaire, che dimostrava, come dire, un andamento abbastanza ottimale del paziente, però lei diceva che nel momento in cui poi invece si è utilizzato il BDI, il Back Depression Inventory, il quadro era molto più, come dire, articolato e complesso, e quindi in questa slide noi vediamo come questo feedback che arriva dal somministrare il BDI in maniera ripetuta al paziente ha dato un feedback al terapeuta importante per poter migliorare l'efficacia del trattamento. Questo cerchiato in rosso adesso è il momento in cui il paziente aveva iniziato a peggiorare in maniera consistente sulla sintomatologia depressiva, che era dopo la pausa di Natale, quindi dopo una breve interruzione della terapia. Nel momento quindi in cui c'è una consapevolezza di questo forte peggioramento che emerge dal questionario, aumenta la frequenza delle sedute di psicoterapia, c'è l'efficacia dell'antidepressivo e quindi si va incontro a una riduzione del sintomo. Però poi le diceva, anche arrivate alla seduta 9-10, anzi 8-9, c'era stata una forte diminuzione del sintomo, ancora non era il livello ottimale che si poteva raggiungere, perché comunque il livello della sintomatologia depressiva aveva ancora una sua rilevanza clinica, e tramite il ROM è stato possibile per il terapeuta capire che tipo di strategie differenti si potevano utilizzare nel lavoro clinico con questo paziente, e quindi di modificare il proprio approccio terapeutico per ottenere dei risultati migliori. Nel momento in cui il terapeuta modifica il suo approccio terapeutico, sulla base di questo feedback, come vedete poi il livello di sintomatologia decresce in maniera molto molto evidente. Thank you, Kim. Sorry.
No, it's fine. I actually understood some of that. So,
Okay.
When we're talking about the different types of feedback systems, this was a very straightforward one, which I just had the score of the patient. And you can see that here, at the moment that the patient deteriorates, that is something we refer to as the patient being not on track in the therapeutic literature. Now, this was just sort of basically a visual inspection. You can clearly see that there is a large increase here, but it's not always that clear. And of course, there's always a little bit of fluctuation. Nobody is scoring like in a straight line down as a client. So when do we know exactly when a patient is not on track? Now, sort of more advanced models, they used something like expected recovery curves, which is basically, you can't see it in this graph, but there's like in the middle between the green line and the red line, there's a predicted course for this patient based on their characteristics. And then the green line represents the line that is better than expected. So if a client scores under the green line, that's an indicator to the therapist that the client is progressing better than would be expected based on their characteristics. Whereas the red line indicates that the client is doing worse than expected. As you can see here, there's a bit of an increase that doesn't qualify yet to be sort of out of the range of what would be expected. Whereas this, this red dot, we see that the increase is in fact, you know, above the 95% certainty. This is a confidence interval. So this is really that we're pretty sure that this is a too large deviation from what we would expect for a client with these characteristics. And so then the routine outcome monitoring actually becomes an active feedback system for the therapist, where the system helps the therapist decide when to act, when a sort of a slight, you know, if it is just a slight fluctuation that is still within the range of what would be expected, or when it's really more than you would expect and really might be important to really act upon this. Do you want to translate, Gianluca? Or?
Yes, yeah, sorry, just one. The construct of feedback, I think it's important to translate into Italian. Allora, in questa slide vediamo quindi che il sistema di feedback funziona attraverso una simulazione di quello che è il livello di cambiamento atteso del paziente, che sarebbe la linea verde, e il livello invece di deterioramento del paziente, cioè loro, in base ai dati che raccolgono nel loro paese, riescono a fare una stima di quello che può essere un cambiamento tutto sommato funzionale in psicoterapia nel corso delle sedute o un livello di deterioramento. E quindi il sistema del feedback al terapeuta si attiva nel momento in cui, come vedete, il paziente va sopra la linea rossa, cioè inizia ad avere dei punteggi o questionari che dimostrano un peggioramento significativo della sua condizione clinica, ed è quello il momento in cui si attiva il sistema del feedback. Ok, thank you.
Wait. Okay, so some systems, they do even more than that. So not just giving the warning signal, but when there is a warning signal, they apply something called clinical support tools, which is, in this particular example, this is from Michael Lambert's system, where they basically ask like an additional questionnaire that assesses some of the therapy processes and then gives a signal. Like, for instance, in this particular case, the therapeutic alliance has a red signal, which means that on certain questions, and these are like showed here, the client scores above the threshold for that question to be problematic. So in addition to just getting the warning signal, you would also get, as a therapist, additional information on what might be going on in this therapy that is not going exactly as we would hope it to be. And so since the therapeutic alliance has a large ceiling effect, if the the client isn't really enthusiastic about what the therapist is doing, it's quickly to signal, because normally clients are very positive about their therapist. So even a question like, I felt cared for and respected as a person, doesn't have a negative answer. It says neutral. It still is lower than clients would normally say with their therapist. So I felt my therapist understood me, neutral. So there's a couple of questions here that you might not think like I felt like I could trust my therapist completely, slightly agree. You would think that's positive, but actually trust is so important in therapy, of course, that you would have to have a very much agree answer in order to, like, almost everyone says that. And if your client doesn't say that, then that's an indication that there might be an issue with the alliance. And so the other areas that this particular clinical support tool assesses are motivation, social support, and life events. Kind of the first three as areas where you could actually like initiate some interventions, whereas the last one is just also as an explanation of why people may have increased, but also as kind of to assess the coping. So sometimes patients are thrown off quite quickly by things happening in their lives, and then it might be good to focus a bit on how they're coping with these stressful situations when they occur. Can I continue? Or
adesso
yeah.
Sorry, Kim, just
Yeah,
2 seconds. Però questo è un chart, un foglio che è tratto dal modello del feedback di Mike Lambert, ed è importante qui visualizzare che queste sono le risposte che ad esempio dà un paziente che è in terapia durante la fase di monitoraggio ROM. L'idea quindi qual è? Che se un paziente inizia a valutare negativamente la propria alleanza, diceva Kim, in genere in questi questionari, se la terapia va sufficientemente bene, il paziente è comunque soddisfatto della relazione col proprio terapeuta, e quindi quando tu inizi ad avere delle risposte negative a un questionario sull'alleanza, questo è un segnale rosso, nel senso ci indica che qualcosa non sta funzionando nella terapia, oppure quando il livello di motivazione del paziente inizia a essere in qualche maniera problematico, come il paziente che dice di annoiarsi nelle sedute o pensa che questa terapia non lo aiuterà a risolvere i suoi problemi. Quindi questo è il primo step del monitoring, cioè il paziente dà dei segnali che qualcosa non sta funzionando nella sua relazione terapeutica, e questo quindi attiva la possibilità, poi vedremo, di intervenire con il terapeuta per fornirgli un feedback su tutto questo. Thank you, Kim.
Okay, so when we see that a client is not on track and it is more than what we would expect, how does that actually relate to negative outcomes? Because if it's just a fluctuation, but it doesn't result in bad outcomes, then that's of no concern. But in fact, there is a pretty clear relationship between the signals given by based on these expected recovery curves and the probability of a negative treatment outcome, treatment failure, as is defined in this study. You can see that if there is no signal, about a third, 30% of the clients will fail treatment. But if there's one signal, that's already 53%. And if there's two signals, it's 70%. And two or more, we're getting to 74%. So there is indeed, when people do signal at least once, there's already a stark increase in the odds of having negative treatment outcomes. And that's even further visible when there's two signals or more. So it's definitely worth paying attention to these signals, as they do have a clear relationship with the probability of treatment failure.
Quindi in questa slide vediamo come la probabilità di un fallimento terapeutico, quindi sostanzialmente di un dropout, è fortemente associata a questi segnali che vedevamo prima negativi che emergono dal monitoring. Quindi nel momento in cui vedete il paziente riceve 2 o 3 segnali, quindi rossi, quegli indicatori negativi a partire dal monitoraggio, c'è un'altissima probabilità di un fallimento terapeutico.
Now, when clients become not on track, what kind of problem patterns do we see? Now, this is based on work by Michael Lambert, using those clinical support tools that we just talked about. And what you can see is that about 20% of the clients who are not on track have problems as a cluster with alliance and motivation. So this is a very commonly also in the scientific literature, that if people are not motivated, it's very hard to form an alliance. And of course, if you don't have a good relationship with your therapist, then the motivation to continue also drops. So this is one cluster that is the case in about 20% of the clients. If we look at the second cluster, there's a cluster with life events and social support. So this is very much a coping cluster. If life events happen and you don't have social support as a client, then you're being completely dependent on the support of your therapist, and it's much harder to cope with these negative life events. So that second cluster is about 30% of the clients. And then there is a third cluster which is called general elevation, which means that these clients have elevated scores on several items on all of those 4 scales. So there's like a general elevation on all of those. They're just having a lot of trouble with the alliance, with motivation, with life events and social support all at the same time.
I think you can go, Kim. It's easy.
Okay.
Quindi diceva, queste sono le percentuali di problemi.
Okay. Okay, so I already showed you, hopefully with the example of my own client, why I think feedback can be really helpful. And I think this is well sort of illustrated by this cartoon made by a Dutch psychotherapist who is also a cartoonist. So the client says, I'm not that satisfied with the therapy. And the therapist says, yes, I understand. That's part of your psychological problems. And I think everyone who is a therapist recognizes this as something that we have a tendency of doing, that when a treatment's not going well, we tend to think, oh, this is because it's a difficult patient. And so it's less common to actually think, well, what can I do differently? Is it something that doesn't work that I'm doing with this particular patient? It just doesn't work for this patient. And this is something cool that we sometimes refer to as a self-serving bias. And I'm going to talk about that a little bit more. This is an illustration of that. So this is a pivotal study by Hannan and colleagues in which they asked clinicians sort of if they could predict the outcomes of their patients. And so the clinicians, they predicted that 3 of their patients would have negative outcomes, whereas in fact, 40 patients had negative outcomes. And this is something that they knew because they were told the base rate, which was 8% in that clinic. They've worked with feedback for years already there. And so they knew that what was the base rate. But when they didn't have the information of the outcome measurements, they were very, very poor in predicting which clients would actually have negative outcomes or would deteriorate during treatment. And in fact, they were accurate only 1 time, which was a very low percentage of the cases that actually deteriorated. Now, when they use something like that expected recovery curve, within 3 sessions, the feedback system was able to correctly identify 77% of the patients that were likely to not benefit from treatment. So you can see that using feedback really is a necessity, as we are generally too optimistic about the outcomes that we will see. And I think that's part of what we do as therapists. We want to have hope for the patient. And so we want to keep believing and that what we're doing will help the patient. And sure, it's not going so well right now, but it'll click at some point, and then the client will get better. So we have these sort of self-talks that we have when a client is not progressing. But actually the feedback can really help us to get into action, to say, wait, but this client is deteriorated to a degree that it's really important that you act upon this right now. I don't know if you want to say something about that.
Yeah, allora, qui come vedete siamo in un punto importante, perché si parte dalla constatazione che spesso quando un paziente non va bene in terapia, appunto il terapeuta spesso può un po' trincerarsi, no? O comunque valutare, basare il suo giudizio sull'idea che è un paziente difficile, che è un paziente che ha resistenza al cambiamento e così via. Ed è invece più complesso per il clinico chiedersi cosa io posso fare invece per migliorare la situazione. Questo tipo di prospettiva poi la possiamo vedere anche negli studi che hanno provato a valutare qual era la capacità del clinico di predire in maniera corretta il peggioramento dei propri pazienti. Ad esempio, in questo studio, come vedete, la percentuale di clinici che riesce ad avere un giudizio corretto su quali dei loro pazienti deteriorano è molto molto bassa. Mentre l'algoritmo del feedback paradossalmente funziona molto meglio nell'identificare correttamente i pazienti che stanno deteriorando. Quindi si pone un problema anche, diciamo così, della scarsa affidabilità del clinico nel momento in cui deve valutare in maniera corretta quali dei suoi pazienti stanno peggiorando. Quindi forse il sistema del feedback può aiutare anche in questo senso, visto che noi professionalmente fatichiamo a cogliere quali pazienti realmente vanno male. Thank you, Kim.
Now, this is what I already discussed, so now I can just move on to the next slide, which is the effectiveness of feedback. So I just published, just in time for this meeting, published a meta-analysis on the effectiveness of feedback in a clinical psychological review. What we found was that when we looked at the overall effect of feedback in reducing the symptoms of patients and sort of helping with that, we see that there's a small but very robust overall effect of feedback, which is has an effect size of 0.15. Now you have to keep in mind that feedback is a relatively small intervention. Of course, it's not going to do more than the entire, you know, all the interventions that you use in therapy. So an effect size of 0.15 is actually a nice effect size for a relatively small intervention. We see that in the not on track cases, it's slightly better, but we also see that under certain circumstances, larger effects of feedback can be achieved, which we'll talk about on the next slides. What's also important is that dropout was reduced by 20% when feedback was used, and that's actually also a very important outcome, and actually may have contributed to the effect size being somewhat smaller, because if you keep in the severe cases that would normally maybe drop out of therapy, then you know, that is also in itself may make it harder to show that it also has an effect on symptom reduction. So that's something to keep in mind. That these are actually communicating vessels. So no effect was found on treatment duration and a marginal effect on the percentage of deteriorated cases. So all of these were, of course, in the favor of feedback compared to no feedback control conditions. So if we look at the full sample, we saw that there were a couple of moderators. So for the overall group, we see that the PCOM system, which is one system is by Scott Miller and Barry Duncan, overall seems to be doing a little bit better than the LQ system and other instruments. And that studies in the US have larger effects than in other countries. Which I think has to do with the fact that there is a lot more variability in the quality of treatment in the US, in terms of that it's less, the training is less regulated. You can get, the access to treatment is actually not great because it's often not covered by insurance companies, and they don't, of course, they don't have any public health almost. So I think that could be potentially something, that there's just a lot more variation naturally in the US that is, so there's more potential to enhance the outcomes, I think, in a country like the US. We also see a slight effect of the earlier studies showing smaller effects and later studies, larger effects and later studies smaller. This is very common in any new intervention. The first studies are going to show very promising results, and then later on it's being applied in different contexts, and then you usually see that the effect size drops a little bit, which is also what we found. What I should mention is that the outcome instrument also influenced the results, particularly that the outcome rating scale, which is part of the PCOM systems, showed much larger effect sizes in terms of than the other outcome instruments, and it's something that's been found as well in other studies. And I looked at also if the ORS was used as well as another instrument in those studies, whether the other instruments showed as favorable an effect, and that was not the case. So I think it's good to remember that this PCOMS effect, very often the PCOMS only uses the outcome rating scale as an outcome measure. So it's good to realize that this might be confounded a little bit and inflated a little bit, because the ORS is just either more sensitive to change or it's inflating the change a little bit.
Sì, allora Kim ci sta mostrando i risultati di questa meta-analisi che ha appena pubblicato sull'effetto del feedback, quindi in cui ha analizzato i risultati emersi finora da tutti gli studi che hanno confrontato quindi la condizione in cui i pazienti o i terapeuti ricevevano il feedback verso quelli che non lo ricevevano. Quindi c'è un effetto comunque del feedback, non elevatissimo, ma c'è in termini di effect size. Soprattutto efficace nella riduzione dei dropout, quindi non tanto per prolungare il trattamento, ma per ridurre il tasso di dropout. E poi l'altra cosa interessante che ci sottolineava è che comunque questi risultati dipendono anche molto, quindi in questa analisi dei moderatori si vede che hanno un peso sicuramente lo strumento del feedback che viene utilizzato, quindi funziona meglio il PCOMS, che è uno strumento sempre sviluppato negli Stati Uniti da Duncan e Miller, molto, molto semplice, molto veloce, e anche lo strumento di outcome che si utilizza può avere un peso abbastanza rilevante poi nel valutare il tasso di miglioramento del paziente nella condizione del feedback. Thank you, Kim.
If we look at the not on track cases, we see that here it looks like the OQ system does a bit better, because they're the only ones that have clinical support tools. And you can clearly see that when you use these clinical support tools, the effect size of feedback is getting larger. So here we find in the group of studies that use clinical support tools, the effective feedback is found to be 0.36. So that's more than, that's almost double of what the overall group effect is.
Anche questo è importante perché dice che nel momento in cui noi forniamo questo strumento di supporto per il clinico, come vedete, l'effetto sul miglioramento del paziente è molto più alto, semplicemente del guardare la curva che vedevamo prima che ci dice, che ci dà il segnale di allarme sul paziente. Quindi quello che sembra essere più efficace è poi fornire al clinico degli strumenti per cambiare il proprio atteggiamento in terapia.
Yeah. If we look at moderators of dropout, we see something similar. We see that the PCOMS has an odd ratio of 0.48. And the OQ system has an odd ratio of 0.21. So this is a much larger effect, which is, again, I think partly due to some inflation of the effect of PCOMS by the use of the no, this is actually dropout, so this is not an inflation. So there is indeed a larger effect, which I actually think is because the PCOMS also has the alliance instruments in there. So I think with respect to dropout, that might be something that's important, because in the PCOM systems, the feedback system is really used as a communication tool with the client. So that means that there's a frequent talk about the alliance when using PCOMs. And I think that really helps with sort of the reduction of dropout. And what we also see that is that, again, especially in the United States, there is a large effect on dropout, less so in other countries. Now, if we look at cost effectiveness, this is from a study from Delgadillo et al. 2017. And we see that this was a cohort study with a control phase and a outcome feedback phase. And this is in British pounds. You see that in the control cases, the mean direct cost of treatment, which was case mix corrected, is actually much higher, significant amount higher than in the outcome feedback cases. So it's also possible that feedback reduces the overall cost of treatment. And I think this includes the investment into the feedback system, so that it may pay for itself.
Questa è una slide invece, come vedete, che si focalizza sugli aspetti legati ai costi della prestazione sanitaria, quindi che farebbero contenti molti manager delle ASP. E qui in questo studio si è visto che il costo, diciamo, di un paziente, no, che segue questo è il sistema ROM, quindi il monitoraggio del suo trattamento col feedback, è molto più basso rispetto invece ai pazienti che non lo seguono. Quindi c'è comunque anche un risparmio di risorse nel momento in cui si utilizza questo tipo di sistema di monitoraggio, il che quindi dice Kim potrebbe aiutare, no, ad acquisire ulteriori finanziamenti su questo tipo di approccio.
Yeah. Okay. Now, we talked about the effectiveness and some moderators, but there are also, from the literature, there's not a lot known about possible mediators, but there is a little bit of research on it that I want to briefly discuss with you. So this is from one of my own studies that I see that I failed to put a reference in for, but it's a 2012 de Jong et al. In Psychotherapy Research, where if we look at the active use of feedback that we see in the, I don't think the graph is very clear. Sorry, I think there's something went wrong with the legenda. So these two, so the lines that go down are the on-track cases in which there's no difference between feedback and no feedback. And in the not on-track cases, we do see that there is less of an increase of symptoms on average, so that's the square ones, than there is in the control group. And so this was only significant if therapists actively use the feedback. And this is also known from other studies that implementation is a very important factor in the effectiveness of feedback. I think that's also watering down the effect in the meta-analysis, for instance, a little bit, because we see that often up to half of the therapists do not actively use the feedback in treatment. So they just, the measurements are there, they don't look at it. They don't use it to inform their treatment. And then, of course, it doesn't have an effect. But there seems to be a fair amount of resistance amongst therapists to use this, even though we know from the research that it has the potential to actually improve outcomes. But there's this still a big problem in routine outcome monitoring.
E qui questi sono i dati di un altro studio dove emerge da un lato il fatto che, come vedete, il feedback funziona soprattutto per i pazienti not on track, quindi quelli che deteriorano, ma col paziente che va bene in terapia il feedback sostanzialmente non apporta un grande beneficio. Ma soprattutto, dice Kim, in questo studio si è visto che c'è anche una grande differenza in funzione di come e quanto il terapeuta usa il feedback. Nel senso che, dice Kim, c'è una grande resistenza comunque ovviamente dei clinici a poi utilizzare attivamente queste informazioni che emergono dal feedback. Quindi il feedback sembra funzionare meglio ovviamente con i terapeuti che poi guardano questo feedback e provano a capire come a partire dal feedback è possibile cambiare qualcosa. Mentre tanti clinici in questi studi in realtà ricevono il feedback ma poi non se ne fanno sostanzialmente nulla.
Now, what we also know from research is that not all therapists, when they get feedback that a client is not on track, are able to actually use that to their advantage. So some therapists, when they get negative feedback, they change their way of doing therapy, they do something with it actively, and then the symptoms go down. But some therapists actually, they stay up or even worsen further. And so what we found and what I found in my research is this has also to some degree to do with how some of the characteristics of the therapist. So therapists who are high in self-efficacy, so they have a lot of, they feel very competent in their role as a therapist, they are more likely to have this pattern, this green pattern. Whereas the therapists who are low in self-efficacy, for them, the feedback is actually very threatening to their self-image. And so they're usually either freeze or they don't know kind of how to use it in a good way and improve outcomes. And then we also see something called regulatory focus, which is whether you are inclined to be motivated by the prevention of failure, or whether you're motivated by the obtaining success. So we all have both of these tendencies. So we're either, you know, we try to prevent failures or we try to be successful. But some people have one stronger and some people have the other stronger. And when we see that therapists who are more focused on preventing failures, when they get negative feedback, they are also more likely to show this pattern and the green pattern. So what we see is that some of the qualities of the therapist influence their ability to use this feedback moment in a constructive way to help therapists get better. And I think that's also why it's important that we provide sufficient training and also hand therapists the tools that they know sort of how to respond on feedback, that they feel confident in what to do when they get negative feedback, so that they can get this kind of more likely to get the green response, so to say.
In questa slide quindi quello che mostra Kim è che nel momento in cui, come vedete, un terapeuta riceve un feedback negativo, nel senso che gli si segnala che il proprio paziente sta peggiorando in terapia, ci sono casi, sarebbe la linea verde, in cui come se il terapeuta inizia a fare qualcosa e il paziente migliora, ma ci sono anche casi in cui questo feedback non riesce a ottenere nessun miglioramento concreto poi nelle condizioni del paziente. Fra le variabili del terapeuta che possono avere un ruolo, che sono state analizzate in questo studio, c'era l'autoefficacia e la regolazione del proprio focus. Dice Kim, ad esempio, che soprattutto i terapeuti che hanno un'autoefficacia molto bassa tendono a vivere il feedback negativo un po' come una disconferma del proprio lavoro, come una minaccia quindi alla propria identità, e quindi non riescono a utilizzare bene il feedback. Similmente, no, pazienti che poi riescono a regolare il proprio focus in funzione invece del feedback che ricevono e quindi cambiare il proprio focus terapeutico, riescono a ottenere dei risultati soddisfacenti. Quindi qua il problema è capire cosa il terapeuta fa una volta che riceve il feedback e quali caratteristiche hanno un peso poi nel capire come viene utilizzato.
I just want to ask with regard to the time, because I think we're going a little bit slower with the translations than anticipated. How much time do we still have? And I want to make sure that there's also maybe time for questions, Because I could potentially stop here and then have people look over the slides that they have themselves.
Vittorio, come tempi, come ci regoliamo? Dice Kim, perché possiamo fermarci qui e iniziare una discussione, oppure lei va un po' più avanti, perché poi abbiamo la tavola rotonda alle...
Ma Gianluca, forse credo che ci siano molti interventi per la discussione, però magari potrebbe concludere ancora, le lasciamo ancora una decina di minuti, poi...
Ok.
Io tra l'altro purtroppo colgo l'occasione per dire che tra poco ho una riunione per la declaratoria e devo scollegarmi, e quindi colgo l'occasione per salutare tutti.
Okay, Kim, I think that you can talk for 10-15 minutes more, and then we have time for questions and discussion. Okay,
Yes.
and then we'll stop at 11:30.
Okay, sounds good.
Kim, I get the chance of this interruption to thank you a lot. Unfortunately, I have a meeting in my faculty, so I have to rush away, but thank you very, very much, and I hope to see you soon.
Okay, great.
Thank you for your talk.
Sure. Okay, so one other thing that might be relevant is that one question that I was wondering at is that does feedback also work with all kinds of patients in an equal way, or are there differences between sort of patients? Does it work better for some patients? So there is, for instance, an earlier meta-analysis that suggested that feedback was especially working for people in counseling settings, but not so much in more severe settings. And so one of the things that this is a work by Dr. Rubis, who wrote this sort of more theoretical paper. This is a simulation study, but it basically shows that the quality of treatment actually matters more when patients become more complex. But of course, if they become too complex, they might not be able to be changed at all. Whereas for very easy patients, you don't actually have to have any therapy. If you're on the waiting list, you're already getting better. And so there's a range of what they call easy patients, pliant patients, and challenging patients, and sort of a few in between that show that, for instance, in pliant patients, when there is no quality of therapy, there will be, no effect. But if there's very high quality, that there will be a very large effect of therapy. And so there will be a lot of improvement in the client. And that this becomes less and less the more challenging the case becomes. So actually, this is sort of the ideal patient, the pliant patient that has the maximum range of possibility to respond. But it also shows that maybe in some patients, we could use feedback to enhance the quality, and that maybe even in this group that is already kind of mild problems, that there wouldn't be that much of a benefit, whereas you would maybe in a bit more challenging cases, but not so much as intractable, but definitely somewhere between pliant and challenging, feedback could actually do a lot of good. So that's what I looked at in one of my own studies that's not yet published, but we're working on, is that I did a rating on the patient complexity, and I created a score that was a sort of a piling up of risk factors. So if patients were either widowed or divorced, they would get a score 1 point on the risk index, so to say. If they had no education or only primary school, they got also a 1. So if people had multiple risk factors, they would get a higher score on this risk index or complexity index, as I called it. And so these were all based on the literature, but also on my own experience in working with this type of data sets for a long time. And I've seen in various data sets these variables come back as predictors of negative outcomes. So that's why I chose these particular ones. Now, when we looked at complexity, we saw that actually in the low complex patients, there was no effective feedback, kind of what you expect. These patients just get better regardless of what you give them. They do quite well. They just need like a therapist that doesn't mess up completely, and they will be fine. Then in the medium complex group, we saw that there was an effective feedback, but it was relatively small. But when we looked at the highly complex patients, we saw something very interesting. And that is, this is a difficult graph, so I'm going to walk you through it. I don't know if you can see my cursor. Can you see the mouse moving or not? Yes? Okay.
Yeah.
That's helpful. So these sort of purple-ish, what is it, magenta, yellow, and red dots are the on-track cases. And we have here a condition with no feedback, with ROM feedback, without any like additional things. And this is expected recovery curves plus clinical support tools. So these are the types of feedback that we already discussed earlier. Now, if we look at the on-track cases, we don't see a huge difference. This is not significant, the difference that we see. So we see the magenta ones here. The colors actually don't match. I don't know why. But this is a weird graph. I need to replace it. Then the yellow one is the feedback just based on the ROM. You see actually that this sort of simple form of feedback seems to be doing us a little bit better for the on-track cases, maybe because it's easier to understand for therapists. That could be a reason. And then we see that the on-track clinical support tool feedback is similar to the regular no feedback, which makes sense because, of course, if they stay on track, they don't get additional feedback signals. So in fact, that condition is similar to no feedback when the client is not on track, if that makes sense. And of course, here they would see graphs and things, whereas in the CST condition, they only get a signal when the client is not on track. So in fact, the feedback is not better than when there's no feedback. Now, if we look at the not on track cases, we see something very interesting, which is that if there's no feedback, this is the course that we see. So this is what we saw in the other graph earlier as well. There's a slight declinations stay up quite high in overall over the course of treatment. If we look at the ROM feedback, and there's a similar pattern, but actually it's getting a bit worse. So it's a bit more elevated. So in fact, the simple feedback doesn't work so well with the not on track cases. Somehow the therapists are not triggered to act upon this feedback when a client is not on track. So however, when they get the on track, the CST feedback for the not on track cases, and this is where the colors don't really match, but do you see this sort of this line? I'm hoping that you can see it. It's very close to the yellow line in sort of a brownish orangey color, beige maybe, is that they start quite high, and then look at that. It's having a similar effect as the on-track cases. So where we previously saw that feedback in the not on-track cases would increase symptoms to some degree, would sort of improve symptoms to some degree, but still, they would typically still be a lot above the on-track cases. And any of Michael Lambert's graphs is what you see. Here, we see that in these complex cases, when we provide not on-track cases with the CST feedback, that the result is similar to the on-track cases, which is a huge difference compared to what we saw in earlier studies. And it's very, very positive signal, I think, especially with these complex cases. And I'm assuming you want to translate that.
Yeah, sorry. Yeah, okay, thank you. Allora, qui stiamo parlando invece di uno studio che è in preparazione e che si focalizza su pazienti, come abbiamo visto prima, complessi, cioè perché ovviamente si è visto che i pazienti che presentano una complessità clinica maggiore, in base a quelle variabili che vedevamo prima, quindi anche su aspetti psicosociali problematici, no? Separati, divorziati, con un basso livello di istruzione, appartenenti a minoranze, quindi ovviamente pazienti che presentano anche delle caratteristiche che generalmente li rendono più difficili nel trattamento. Ecco, in questo studio in cui sono state valutate 3 condizioni di assenza di feedback con il ROM semplice, cioè in cui il terapeuta vede soltanto l'andamento sintomatico del paziente nel corso delle sedute, e la condizione CST, che è il Clinical Support Tool, quindi in cui poi viene fornito al terapeuta un feedback su cosa potrebbe migliorare nella gestione della sua relazione terapeutica col paziente. Quello che emerge è che, come vedete, nei casi difficili, quelli not on track, che sono quelli superiori, il semplice feedback dato con il ROM, cioè semplicemente con il monitoraggio dell'andamento del paziente, non funziona, mentre funziona molto bene con questi casi difficili il Clinical Support Tool, cioè il feedback che diamo al terapeuta con delle indicazioni su cosa modificare nella sua relazione col paziente. E con i casi difficili quindi sembra essere un feedback molto efficace. Thank you, Kim.
Okay. So now I want to discuss some possible mechanisms of action with you, which is sort of why does feedback improve outcomes? And there's very little work on this, but there's still a few studies that generate some hypotheses about why feedback might be helpful. This is from a study from Susan Douglas and colleagues, in which they looked at how quickly certain topics that were important to the client were discussed when the therapists were getting feedback compared to when they were not getting feedback. And as you can see in this survival plot, if we look at the red line, that's the line when feedback was provided. And this is the time until a topic that was important to the client was discussed. So what you can see is that in the feedback condition, that curve is steeper. So that means that it's quicker. So it's the topics are discussed sooner by the client in the feedback condition than when there's no feedback. So that might be something that there is, you know, maybe blind spots at the side of the therapist, or maybe the patient is more reluctant to withhold information, you know, they're withholding information or something like that. So with feedback, important topics to the clients are discussed sooner, which may be why it helps.
Quindi in questo grafico vediamo come il tempo, no, della terapia si riduca nella condizione in cui si riceve il feedback rispetto a no, e questo può essere legato al fatto che il terapeuta nel momento in cui riceve il feedback ha maggiore capacità di discutere precocemente in terapia alcuni aspetti problematici del paziente o della relazione terapeutica.
Another hypothesis from one of my own studies is that maybe the feedback changes the clinician's expectations. So remember how we talked about the self-serving bias earlier, that we're too optimistic. Now, if we look at this same study in which I just showed you for the different groups, the study with the complexity, which we looked at complexity, we also looked at clinicians' expectations at session 5 and session 10. Of the therapy, and then we looked at the light blue one is the actual treatment outcome. And so we asked, actually in this case, the positive variant, because it's harder to predict negative information than it is to predict positive information. Because the negative is relatively more rare, so it's always harder to predict rare examples than it is to predict sort of more common ones. So we asked basically, you know, for each of the clients, to what extent they would expect this client to achieve treatment, a positive treatment outcome. And what you can see here is that, and this was actually defined as clinical significant change. So that's usually only about a third of the clients. Now, this is what we saw. Therapists thought that about 65 or 67% at session 10 percent of their clients would achieve clinical significant change. And in fact, it was only 36%. So you see, this is an illustration of what we also saw in Hannon's study, that there's a gross overestimation by therapists of the chance that their client will obtain recovery during the course of treatment. Now, when we looked at the simple feedback with just a ROM, you see that the ratings are pretty similar. So this type of feedback does not affect the estimations of the therapist much, but because there is better outcomes because of the feedback, we see that this is actually now much closer together. But it's not because the therapist changed their opinion, but it's because the outcomes are better. Now, if we look at the CST feedback, we see that at session 5, the therapists still think the chances of outcome of recovery are pretty good. So here there's no change. But if we look at session 10, now we actually see that for these clients, the therapists are more realistic. It's actually very close to the actual outcomes. So again, here the outcomes are enhanced a bit compared to this, to the no feedback group, but actually the therapists, they adjust their evaluation.
Sì, traduco velocemente. Allora, questo è sempre lo studio con i casi complessi. E qui però ci focalizziamo sulle aspettative del terapeuta sul cambiamento positivo dei propri pazienti. Quindi, quello diciamo prima, quanto il terapeuta è in grado di predire quali dei suoi pazienti andranno bene in terapia o meno. E ovviamente quello che vediamo è che nella condizione in assenza di feedback, come abbiamo visto precedentemente, il terapeuta è molto ottimistico circa l'outcome dei propri pazienti, mentre il dato attuale è molto più basso, per il 36%. La situazione cambia invece nelle due condizioni di feedback, in cui rimane ovviamente alta l'aspettativa del terapeuta circa il miglioramento dei propri pazienti, però questo si avvicina maggiormente con quello che è il cambiamento positivo del paziente nella realtà. Ovviamente un cambiamento, dice Kim, è anche legato al fatto che i clinici ricevono il feedback e quindi il feedback ha anche un effetto positivo sul cambiamento del paziente. E questo ancora una volta è molto forte nella condizione in cui il terapeuta riceve il clinical support tool, quindi delle indicazioni su come migliorare la propria reazione terapeutica, e qui come vedete il proprio tasso di aspettativa, il 48%, è quasi identico alla realtà del paziente, che cambia in maniera positiva nel 46% dei casi. I think, Kim, that you can go to your conclusions. So
yes, I was almost there, so that's good. Yeah. So just to summarize what we talked about already is that the overall feedback is effective feedback is small, but it's robust. And it also has a positive effect on dropout, not just on symptom reduction. What we see is that it seems that depending on the complexity of the patient, it might be wise to use either one feedback system or another. So there's differences between feedback systems like PCOMS and the CST feedback from Lambert, for instance, in where they work well. In the overall cases, sort of, and also as a consequence, the on-track cases, a simple feedback seems to be doing a bit better. It's easier for therapists to understand and to talk about with their patients, perhaps. But with the not on-track cases, actually, feedback systems that have these clinical support tools, and then we see especially in complex patients, is really helping patients get better outcomes, especially you know, these are very vulnerable patients, so it's important then that we offer a bit more than just the scores in those particular cases to really help the therapist to enhance the outcomes for their patients. And then we also see that some therapist characteristics influence the effectiveness of feedback, that therapists really need to feel confident in using it and knowing what to do when a client is not on track. And that in that sense, a positive attitude, active use, and proper training are probably quite important. And I actually think that that last sentence is not complete. So I'm going to wrap that up right now. And so this is what I had to say today. Thank you for listening to me. And I'm curious to hear your reactions as well as questions.
Thank you, Kim. Great presentation. And now we have 10 minutes for questions and discussion about your presentation. So, possiamo chiedere ai partecipanti se hanno domande o anche, direi, sensazioni a partire da quello che Kim ci ha mostrato su un lavoro ovviamente svolto tra l'Europa e gli Stati Uniti. E quindi sicuramente potete fare sia delle domande più tecniche su alcuni aspetti che ha esposto, oppure anche sensazioni, no, sull'utilità di questo sistema, anche sulla vostra percezione da clinici su quanto possa essere utile o accettabile un sistema di questo tipo.
Luca, io avrei una domanda.
Vai Mauro.
La faccio in italiano o in inglese? Forse meglio in inglese.
Ma prova in inglese, sì, così ti sento subito. Grazie Mauro.
Thank you, Kim, for your wonderful presentation. Your findings are very useful for me because I think that I have a role in training new psychotherapists, and I hope that your findings could help me support my statements, my talks. But my question concerns online therapies. I think that feedback on the progress of therapy could be even more beneficial in online therapies. So I would like to ask you if you know if there are studies published or under publication or in preparation that assess the effects of feedback in online therapies.
I absolutely agree that it is potentially even more important in online therapies. I don't think that there is at the moment something that is published on that. However, I do know that there is a publication by Susan Douglas that is very recently accepted, I think, like either this year or last year, in which she writes like a kind of educated opinion piece on this. So without, I think, actually having, I don't know if there's data in that piece, but I know that she wrote something with an expert on e-health applications, that she wrote an article on that. So Susan Douglas would be the name to look for.
Could you write names of your colleague in the chat?
Douglas.
Thank you very much.
I think there's a question in the chat as well. Can you translate, Gianluca?
Yeah.
Gianluca, ho alzato la mano, non so se si vede, posso fare una domanda?
Puoi farla adesso? Vai Jong.
Oppure la scrivo in chat, ok.
No, falla, dai, vai.
Okay, thank you, Kim. It was very interesting, your speech, a very interesting approach. I have many questions, but I need to choose. And the first is if you found any differences on the efficacy of the ROM based on the diagnosis of patients. So if you if you could verify if the feedback is more efficacy with, I don't know, with this, some types of patients with the different diagnosis. And if you could share, if you can give an example of the clinical support tool, how do you explain, what do you say to the therapists when you give them a feedback? Just an example in order to understand how the clinical support tool function with therapists.
Yeah.
Thank you.
Okay. Oh, now I've forgotten the first question that you asked.
Regarding the diagnosis of patients.
Yes. Yeah. So there's limited work on this, but there is a little bit of work that suggests that very severe patients do not benefit from feedback. And then we're talking about crisis care. There's a study from Flip-Jan van Oenen that shows that in crisis care, patients actually get worse when you provide, and this was the PCOMS that was used. So I think when people are in crisis, when they are in acute situations, that they just can't really handle when they don't progress. So it's not a very nice message. They don't have a lot of space, I think, to be able to absorb that message. And I also did one study myself in a clinical setting for personality disorders. So this was an inpatient setting. This is the most severe personality disorders that we have in settings in the Netherlands. So these have already had years of outpatient therapy already. And so this is kind of a last resort type of treatment for these patients. And in those patients, the borderline patients, they had a lot of trouble dealing with negative feedback, when we provided the feedback to patients as well. This was a study in which we also gave the feedback to the patients, and that they didn't do well with that. Although their overall outcomes in the end of treatment were not worse than people who did not get feedback, but in the beginning of treatment, they had a lot of trouble dealing with the negative feedback message. Whereas the cluster C patients actually did benefit, even though they were severe cluster C patients, they were much better able to deal with negative feedback than the borderline patients. So that's with respect to diagnosis. And then the second question was about the clinical support tools, and that was actually in the presentation all the way in the beginning, but I can understand that that has been a little while ago. So I'm going to show you that picture from Lambert's. Let me see if I can.
You can start sharing the screen again.
Yeah, I will. So that was this. I don't know if you can see it properly.
Yeah.
So this is what the information. So the client, so the clinical support tool system is a combination of getting an active warning system by the underlying prediction model, and then having that extra questionnaire assessing some of the therapy processes. So in this particular example, for instance, and then, so this is the additional information that the therapist gets. So here you can see that there is an alliance problem, that there is a motivation problem. There's some question of social support are not scored favorably, and there's some life events going on with this particular client. So as a therapist, you can then go over these questions, look at sort of, think about what can I do differently. But it also comes with a treatment manual that has suggestions based on the scientific literature. So for instance, for the Therapeutic Alliance, one of the advices, for instance, is apologize to the patient. Or that's something that's known from the scientific literature, that whenever there's an issue with the alliance, it's better to apologize. A lot of therapists, they respond by explaining themselves. So that comes over as defensive. Whereas if you apologize and say, I'm sorry that I made you feel like you couldn't trust me, for instance, can we talk about it? I think that sort of what is known from the alliance literature as an effective way of dealing with the intervention. The other thing about the alliance is that a lot of therapists think that the alliance is mostly about the bond, but the more predictive part of the alliance is actually about being on the same page with respect to treatment goals and who does what in therapy, and sort of the tasks that are being done. And so that's also another advice that comes from that manual that says, you know, revisit the treatment goals. Are you still on the same page? And do you still have the same expectations of, you know, what needs to be done in order to achieve those goals? And so that's another advice. So there's, for each of these domains, there is kind of a little bit of like a summary of the scientific literature on these topics that is accessible to the therapists.
Kim, is it the same model by Mike Lambert, or you have updated the clinical support tool?
No, it's the same. The one that I used in my study is the same. Yeah.
The assessment for senior client.
Yeah. That's the questionnaire.
40 items.
Yeah, exactly. Yeah.
Noi nel 2003 pubblicammo un lavoro in italiano, ma non ebbe grande fortuna sul Clinical Support Tool di Lambert, nella rivista Ricerca in Psicoterapia. Boh, se lo trovo te lo mando, ma era in cartaceo, non c'è neanche la versione online, però casomai lo posso scansionare. There are two more questions. One is in English in the chat.
Yeah, I already answered it. I think Angela was
okay. And the previous one was on the question is if there are some studies on Rome in therapy with adolescents.
Yes, there are. They're not a lot, I should say. It's very rare. There are only about I think maybe 5 or 6 studies done in youth overall with feedback. But there are a lot of, there are also a couple of instruments available. So for instance, I work with the Youth Outcome Questionnaire, which is from Lambert's groups. It's a very different questionnaire, by the way, than the regular outcome questionnaire. There's also a youth ORS, so there's a youth system for PCOMs as well. So there are a couple of options available for those who want to work with youth, but we didn't see an effect of being either in a youth population or an adult population in terms of the effect size in the meta-analysis. So we did look for whether there was a differential effect, and there wasn't.
La risposta è ci sono alcuni studi su questo, non tanti però ci sono, con degli strumenti ovviamente riadattati per gli adolescenti. Nella meta-analisi però di Kim lei non ha trovato un effetto significativo dell'età dei pazienti sull'efficacia del feedback, quindi sostanzialmente funziona alla stessa maniera per adolescenti e pazienti adulti. I think that maybe we have time for a last question.
Magari posso fare io, Gianluca, una domanda.
Certo.
Allora, innanzitutto ancora grazie a Kim per questa presentazione. Kim è stata visiting professor a Bergamo. Ci sono degli elementi di curiosità all'interno dei dati che lei presenta. Mi sembra che lo strumento di Lambert e anche lo strumento che qui viene indicato, l'Assessment for Senior Client, di 40 item più quello di Lambert che è 45 item, chiedono al paziente di compilare 85 item session by session. Se così è, la domanda è: qual è il percepito del paziente in termini poi di investimento emotivo, anche se vuoi anche di condizione stressante, no? Nel momento in cui ad ogni sessione, dopo ogni sessione, deve compilare un questionario di 85 item. L'altro tema è il seguente. Abbiamo visto, a parte questo strumento completo che è l'Assessment for Senior Client, che valuta anche l'alleanza terapeutica, tendenzialmente il monitoring si sofferma sull'outcome, ok? quindi ci dà una predizione dell'outcome, ci fa capire se il soggetto è o no on track, quindi secondo una linea di esito di trattamento, però sarebbe interessante avere anche feedback sul processo. Sappiamo quanto l'alleanza terapeutica è importante e quindi l'integrazione di informazioni di outcome insieme a informazioni di processo sarebbero molto utili per il terapeuta per poter andare a cogliere, come sappiamo, quei momenti di rottura dell'alleanza terapeutica che, se diciamo colti in anticipo, permettono addirittura di risolverli e poi di aumentare l'alleanza.
Kim, did you get it? No.
No.
And the first question is regarding the questionnaire for patients, because Angelo said, is it too long in your experience? Because we have 45 items from the OQ45, the ASG is 40 items or so on. So is it heavy for patients to complete this questionnaire on a session by session basis in the system? Because I think that it could be a barrier to the implementation of the ROM in clinical practice. And the second question is, there's a second question by Angelo, is if it could be useful to use also a measure of alliance and monitor the level of alliance across sessions in feedback system.
Mm-hmm. Yeah, so with respect to the first question, that has not really been my experience. So my experience has been that a lot of therapists really come up with this as a reason very often, that they think it's too much of a burden to do a session, 45-item questionnaire on a session-by-session basis. But actually, in none of the studies that I've done with the OQ45 was that brought up by patients, or did patients massively drop filling out the questionnaire at some point. In fact, especially when they are in a feedback condition and can see their progress, patients actually value it very much. So there's a study, for instance, by Lutz that shows that patients give like on a 10-point scale, I think like above an 8 on average, for how they value the feedback, and about 90% says that they are, they think it's important for treatment. So patients actually have a very favorable attitude towards using these types of instruments as part of the treatment. And it's more the therapists actually that don't have that kind of attitude, as we also saw in the presentation. So with respect to monitoring the alliance, I think Lambert and Duncan and Barry have a different approach to it. So so Miller and Duncan, they do it on a session-by-session basis, so that you can basically continuously assess that. Whereas Lambert says, well, as long as the therapy is progressing, you don't need to ask for the alliance, but we ask it when a client is not on track. So I think it's a different approach. I don't think that one is necessarily better than the other. I think it's just a different approach. So Miller and Duncan, they really focus on brief instruments that are used in session, mostly as a communication tool. And I think that's really the strength of the PCOM system. It's very brief, it's all completed within the session. The downside is that it's always completed in the presence of the therapist. So there can be a bit of bias because of that. And it's very global. So that's, I think, are the downsides of the PCOM systems. But it definitely is, in terms of implementation, easier to implement because it's done in the chamber with the therapist there. So you get much higher completion rates, for instance, but also that it's really used as a communication tool. Whereas the OQ is obviously completed in the waiting room. And if therapists choose to not look at the graphs, they can get away with that. So I think in terms of implementation, that's definitely an aspect to be considering. But yeah, I think in itself, whether you do it on a session-by-session basis or whether you would do it just when the client is not on track, I think that in the end doesn't really matter as much, as long as you do assess it when you need to assess it.
Okay, Kim, thank you. Great presentation, and also for the opportunity to discuss your findings with us. I think that we can stop this first part of the seminar. So Kim, you are free. You can drop and get back to your work.
You can drop
you.
out.
Enjoy the rest of your day, and thank you for having me. And I hope that you've learned something more about feedback and routine outcome monitoring that you may not have known before. Okay,
Thank you, Kim.
bye.
Again, bye-bye. Bye.
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 Non so se vogliamo fare una pausa proprio di 5 minuti, giusto per rifiatare, e poi possiamo dare avvio alla tavola rotonda invece sulle esperienze italiane con il feedback. Abbiamo 3 interventi, quindi penso che se iniziamo 12 meno un quarto riusciamo a stare comunque dentro.
Gianluca, io approfitto per salutarvi tutti, vi devo per forza lasciare. È stato interessantissimo e insomma spero che ci siano altre occasioni per approfondire temi così importanti per la clinica. Buona continuazione.
Ciao Mauro, grazie.
Ciao. Senti Gianluca, però poi la risposta di Kim a questa cosa per gli altri, insomma, la risposta sul numero di items era elevato, era percepito?
No, la risposta di Kim sostanzialmente era che nella sua esperienza non sono tanti pazienti ad avere difficoltà sul numero degli item, sui questionari, sono più i terapeuti che hanno resistenza a utilizzare questo tipo di approccio.
Però 85 item sono
che...
veramente tanti, 85 item, session by session, no, sono tanti.
Quello è un sistema che si può tarare come vuoi, Angelo. Ad esempio Lambert ha sempre utilizzato soltanto l'OQ45 come strumento di monitoring, che loro sono abituati a fare normalmente, quindi è chiaro che è anche una questione culturale, no? Di quanto poi il paziente è anche abituato a ricevere un questionario, cosa che in Italia sicuramente è ancora meno presente.
Però quel tool di supporto clinico si basa proprio sull'altro strumento che viene aggiunto all'OQ45, quello di 40 item. Ecco perché dico 85 poi alla fine, capito?
Sì, però quello lì si è aggiunto nel momento in cui, dice Kim, il paziente inizia ad andare male in terapia. Quindi non lo fai a tutti i pazienti, ma lo fai soltanto nel caso in cui il paziente inizia ad entrare nell'area del non track.
Ok, quindi il supporto a quel punto ce l'hai, ho capito, quello lo utilizzi per andare a fare, a valutare qual è il problema, potrebbe essere il problema, e quindi poi dai il supporto clinico al paziente.
Solo quando è Newton track, solo quando fuori dalla curva a testa.
Sì.
Va bene, comunque di tutte queste cose penso discuteremo adesso nella tavola rotonda che segue, quindi facciamo 3 minuti o 5 minuti? Daniela, che dici? 5? Va bene, 5 minuti per un caffè e poi riprendiamo. A fra poco.